from with colleagues at RCC, Trivandrum, and Palliamindy and the National Cancer Grid. So it's certainly a privilege to be with you today. I'm just going to share a screen here. There we go. Can you see slides now, Chandra?
Yes, we can.
Yeah, great. Okay. Thanks very much. So the structure of this evening's session is I'm going to speak for about 15 or 20 minutes about bias, spin, and hype in cancer randomized trials. And then my colleague, Dr. Merchant, will speak about some of the challenges with another form of medical evidence, which is observational research. And I just wanted to acknowledge my mentor, Dr. Tanik, who has shared some of the slides that I'm going to be using this evening. So the first few minutes, I just want to touch on something that this is a problem largely in medical oncology. I know we're speaking mostly. Just wondering if someone can put their phone on mute. It's a little bit loud. Thank you. And so I know the audience is predominantly surgeons today, but certainly within medical oncology, we have what I call a crisis in the value of cancer care. And this is most acute with our expensive medicines. Some of our cancer medicines provide tremendous benefits to patients, but the problem is a lot of our medicines have very, very marginal gains. So this is a famous study, somewhat embarrassingly from Canada, where it was deemed to be a home run for pancreas cancer with the addition of erlotinib. But as you can see, the median gain in overall survival was 10 days, which is really not any significant improvement for our patients. And of course, these medicines have substantial costs and side effect profiles. Notably, this medicine is not approved for use in Canada, although it did receive approval for use in the United States, but we do not use this medicine in Canada. Another more recent one was in the context of breast cancer, where there was a median gain in progression-free survival of 3 days. And so this is a real problem where we see a p-value with many zeros behind it, so it's statistically significant, but it is nowhere near clinically significant. It's clinically irrelevant, and I actually think it's irresponsible for us as a community to be designing trials that are so large that they are powered to detect these trivial gains. So in the context of bias, spin, and hype, the first few moments here we'll be talking about some of the hype. And you know, I'm a medical oncologist, and I certainly use many cancer medicines in my clinical practice every day that have a major improvement for our patients. But the focus today is going to be speaking about low-value care, and this is not just a problem in low resource healthcare settings. This is a problem all over the world. So this is something we struggle with even in Canada, which is a relatively affluent healthcare system compared to many healthcare systems worldwide. So this is a piece of work we published now over a decade ago in the Journal of Clinical Oncology. We tracked randomized trials over 30 years, and we found that clinical trials are becoming larger. They are now powered to detect smaller and smaller benefits. Authors of clinical trials are increasingly likely to hype or overemphasize these small benefits. And we've also shifted towards surrogate endpoints. 10 or 20 years ago, we routinely measured overall survival as the primary endpoint of clinical trials. And that has now fallen away as we have been seduced by surrogate endpoints, largely progression-free survival. And this is a major problem in our field. There are a handful of circumstances where progression-free survival is a valid surrogate for overall survival. But we radically overuse these endpoints, and it's very uncertain whether they offer any meaningful gains to patients. At the end of the day, progression-free survival is just a measurement on a CAT scan, and what we really need to measure is what matters to patients, which is overall survival and quality of life. This was an updated study we published a few years later, where you can see over time on the horizontal axis, you can see decade, and you can see the clinical trial, the size of trials has risen over time. And now we're in a situation where almost all trials of medical oncology are funded by the pharmaceutical industry. This is the third paper in the series, and we just published this actually last month in JAMA Oncology. And again, you can see that over time, overall survival has been largely replaced by progression-free survival. And you can see now, at least in medical oncology, about 90% of all clinical trials are funded by the pharmaceutical industry. And you can see at the top in red here, amongst those quote unquote positive trials, so amongst those trials with a statistically significant difference in favor of the new treatment, the median improvement in overall survival was 3 months. And so, obviously, some of these treatments have large benefits, but on a whole, here, we're chasing very marginal gains with very, very expensive therapies. This is a piece of work from my friend and colleague, Dr. Vinay Prasad in California, and you can see over a decade, while the median household income in the United States has remained relatively stable with adjusted for inflation, the skyrocketing cost of cancer medicines has vastly outstripped any other economic indicator within our systems. A few years ago, ASCO and ESMO came out with value framework tools, and this allowed us to compare the extent to which one new cancer medicine improves outcome compared to others. And so we could now objectively measure the extent to which our treatments improve outcome for patients. And so it considers the two really most important things, which is how big is the benefit or the effect size, and what is the benefit, what is the endpoint? Is it overall survival or is it a surrogate? And then, of course, you can add or subtract points for quality of life and side effects. And so for ESMO, to meet a threshold of what would be considered clinically meaningful by ESMO, this just gives you an idea of how much improvement we would need. We would need a new treatment in metastatic pancreas cancer to improve median survival by at least 3 months, a 5 month gain in metastatic lung cancer, and a 9 month gain in median survival for metastatic colorectal cancer. And as many as you will know from reading JCO and Lancet Oncology and JAMA Oncology, it's very often that we have a positive clinical trial which improves survival by only 1 or 2 months. So a lot of our trials are below these thresholds. This is a paper actually that we worked on during my sabbatical in Trivandrum at RCC Trivandrum in 2016, and you can see several authors here are from India's cancer system, where we took the ESMO tool and we applied it to all clinical trials in 3 major cancer sites. And amongst those that were quote unquote statistically positive, we found that only 30% met ESMO's threshold for clinically meaningful benefit. So you can see that only a handful of clinical trials identify therapies with real benefits for patients. The other problem, of course, is that when we track this, and this is an updated analysis we published in Lancet Oncology, you can see that not only is there no association between the magnitude of benefit and drug price, if anything, there's an inverse relationship where the drugs with the smallest benefit actually cost the most money. So that's some of the problems with hype in clinical trials. We're now going to shift into comments about bias. And one of the biggest issues is conflict of interest. And as I've said, more than 90% of clinical trials in cancer medicines are now funded by the pharmaceutical industry. And as you can see, the pharmaceutical industry has different goals from clinical doctors. And the pharmaceutical industry obviously is beholden to shareholders, and they want to find useful medicines, but they also need to provide profits for shareholders. And so there's this tension, but multiple studies have shown that payments from pharmaceutical companies to physicians influence practice, they influence guidelines, and just declaring a conflict of interest does not prevent bias. So this is something we need to be mindful in our field of because we do so much work with the pharmaceutical industry. So now we're going to spend a few minutes looking at spin and bias in the reporting of clinical trials. And again, just to set the stage, I know most of the audience today is surgeons, but this is a problem in surgical trials, medical oncology trials. And so we're focusing on clinical trials now. And then in a few minutes, I'm going to hand over to Dr. Merchant, and we're going to shift to talking about some of the challenges in interpreting observational or non-randomized data. So, as clinicians, when we read a phase 3 clinical trial, these are some things that we should be looking at. Is the primary endpoint explicitly defined? Does the primary endpoint reflect benefit to patients, or is it measuring something trivial? Does the concluding sentence of the abstract focus on the primary endpoint, or is it looking at a secondary endpoint and trying to spin the abstract as being positive when really it was negative? And our group and others have done a lot of studies where we've looked at abstracts of clinical trials, and we found over and over again the authors of clinical trials often present their results as being more positive than they truly are. some of that's human nature. After spending years working on a project, we want to find some signal of benefit. This was a piece of work done by my colleague at Queen's University, Dr. Vera Badillo and Dr. Tannick, where they looked at a number of randomized trials for breast cancer, and they found that more than half of these trials used a secondary endpoint to suggest benefit, even though the primary endpoint was negative. And there's been similar findings in other forms of clinical trials. So we need to be careful as well of secondary analyses, because secondary analyses, as the example here for colon cancer, when they did a secondary analysis of this clinical trial, they found that chemotherapy was more effective in men and older patients. But asking the same question with another data set found that it was more effective in women and younger patients. And this just shows that there's a lot of statistical artifact when you begin data dredging and doing secondary analyses, which is why we have to be very careful of secondary analyses. The other issue is ghostwriting. So the pharmaceutical industry often has writers that shape the trial report, and these authors may or may not be acknowledged. And again, this is something that can influence and provide bias in the reporting of clinical trials. One of the biggest problems in understanding clinical trials is something that our group and others have written about called the efficacy to effectiveness gap. And efficacy refers to outcomes achieved in clinical trials, or quote unquote ideal circumstances. Effectiveness refers to the outcomes that we achieve in routine practice. And as all of you know, the patients that go on clinical trials look very different from the patients that we see every day in our clinical practice in Kingston, where I work in Ontario, Canada, or at RCC Trivandrum, or in Paris or Australia, or in Ghana. The patients that we treat in routine practice tend to be older, sicker, and have more comorbidity than the patients in clinical trials. And so this leads to a gap in outcomes, whereby the outcomes in clinical trials are almost always better than the outcomes in the real world. As we mentioned, patients are highly selected, and the benefits that we see in trials often do not translate to the real world, or at least they might be smaller. This is an example from our new Templeton looking at utilization of chemotherapy for prostate cancer. In the pivotal trial, median survival was 19 months, but when they looked at patients in routine practice at the same hospital that did the trial, Princess Margaret Cancer Center, they found that median survival was only 14 months, and there was a much higher rate of septic neutropenia. This is a large study published recently where they looked at thousands and thousands of trial participants compared to patients in the real world. And over again, across every trial, they found that the benefits in the real world were smaller than they were in clinical trials. And again, this is something that we've thought a lot about. Dr. Tannick and I wrote this a number of years ago, where the randomized trial remains the best measure of efficacy because of randomization, but population-based studies can give us a lot of information about access to care, quality of care, and outcomes. And this is a lot of the work that I do with colleagues, Dr. Aliema Matthew, Dr. Chandra Mohan, and others at RCC Trivandrum, and also with colleagues at the National Cancer Grid to understand what are some of the barriers to delivering high quality care in routine clinical practice in the Indian context. And of course, Dr. Merchant and I do a lot of the similar work in Canada, where we have the same problems between these gaps from trials to clinical practice. So just in closing, before I hand over to Dr. Merchant, most clinical trials are funded by the pharmaceutical industry. The pharmaceutical industry needs to sell medicines. And while they often want to also find medicines that are very helpful, there can be a conflict between the goals of the pharmaceutical industry and the goals of clinical doctors. And so as oncologists, we need to be critical but constructive when we read the reports of clinical trials, and we need to understand that there can be spin and bias in trial reports. But most importantly, I think as a community, we need to be wary of hype, and we need to have honest conversations with ourselves and with our patients about the extent to which our new therapies actually offer real benefit. And so my final slide really gets to the concept of clinical benefit. And this is what I do every day whenever I read a clinical trial. And I would encourage all clinicians, we need to think about what is the endpoint that was measured. Is it something useful to patients like overall survival or quality of life? Or is it an endpoint that really does not matter to patients? What is the effect size? Is it very small or is it reasonable? And at the end of the day, Do these matter to patients in the context of a healthcare system that's trying to provide care for all patients, care that is patient-centered with minimal clinical toxicity and minimal financial toxicity? So thank you for the opportunity to share these thoughts. I'm going to now hand over to my colleague, Dr. Merchant, to speak about some of the concepts that we grapple with when we look at another form of medical evidence, which is observational data. Thanks again, and so I'll hand over to you, Dr. Merchant.
Thank you, Chris. I think we will discuss any queries towards the end. Dr. Shaila, please go ahead with your presentation.
All right, thanks so much. I'm going to go ahead and try to share my screen here. Okay.
Yes, we can see it.
Okay. Let me just make sure I can see my own screen here. Give me a second. Okay, can you see that in slideshow presentation?
We can see.
Yeah. Okay. Okay. Very, very good. Thank you. Okay. So thanks so much for the opportunity to speak today on the topic of utilization of routinely collected healthcare data in surgical research, also known as using population level data for surgical research. So some of you in the audience may have experience with using this type of data for research, or you might be thinking about doing something like this in the future. So hopefully this will provide you with some guidance. And I have no relevant disclosures. So as part of the presentation, we will review some of the elements of the STROBE and the RECORD guidelines and put some of the concepts into context by working through a paper. So the growing availability of data generated during healthcare delivery and through monitoring of disease incidence and outcomes has transformed the research landscape. These data are generated in various healthcare settings and geographic locations and present opportunities for innovative, efficient, and cost-effective research to inform decisions in clinical medicine, health services planning, and public health. While the explosion in data availability presents significant opportunities to answer research questions, it also poses challenges for those undertaking and evaluating the research and implementing its findings. The broad spectrum of routinely collected health data sources and the rapid expansion of the field makes it challenging to identify strengths and limitations, associated biases of individual data sources. Incomplete or inadequate reporting of research based on routinely collected data often exacerbates these challenges. So guidelines have been developed to guide the reporting for a range of study designs or associated with improved quality of reporting. The strengthening and reporting of observational studies in epidemiology or STROBE statement was developed to enhance the transparency of reporting of observational research. However, as the STROBE statement is designed to apply to all observational studies, including cohort, case control, and cross-sectional studies, specific issues related to reporting research using routinely collected data are not addressed by those guidelines. Therefore, the RECORD extension was formulated to enhance the reporting of research that uses routinely collected health administrative data. So for example, these are data that are collected as part of routine healthcare that the patient receives, such as inpatient hospital admissions, cancer-related treatment, and visits to the emergency department, just to name a few. I would like to take the next few minutes to highlight some of the elements of the STROBE statement and the RECORD extension, and then put this into context with a paper that we can review together. There are 22 items in STROBE and several additional elements in the RECORD guidelines. Now, these statements are really the key elements that you should consider reporting in your research study. The references for these papers should have been previously emailed to you, but if not, they're easy to find online, and I've also referenced them in this presentation. Now, all of these elements are important, but I will very briefly highlight a few that I feel are particularly important and sometimes not well addressed in research studies that I have reviewed. So we'll start with item number 3 that I've highlighted here, which suggests that specific objectives and pre-specified hypotheses should be stated in your study. Now, when embarking on a study, it is important to have a well-defined question in mind. This may seem totally obvious, but because there is so much data available in these databases, it is very easy to just go and mine the data to see what comes up. Spending time thinking about what your question is and what your objectives are, why they are important and necessary to address, and whether the available data in the databases can actually answer your question is really fundamental to any research study. Now, item 7 here suggests that clearly defining what outcomes you are looking at, the exposure, the variables or predictors and potential confounders is an important consideration and will make things much smoother for subsequent analyses. Often the outcomes and variables are defined in these databases with codes, and so providing an appendix which contains a list of relevant codes is important and is outlined in the record extension 7.1. Now, in my own research, I often look at what others have done and try to see if a list of codes is provided so that I can either build upon this, or if ever I needed to do something similar or check results, I could then follow the codes and methods and hopefully arrive at similar results. Identifying sources of bias from the outset and explaining ways in which you tried to address these biases in the methodology is important and is highlighted in item 9. Bias is really any trend or deviation from the truth and can be present in various aspects of the study, from data collection to analysis to interpretation and publication, which can lead to false conclusions. Now, we will discuss some different biases in the paper that we will review together shortly. So showing how you arrived at the final cohort of patients is a key element and usually illustrated well with the use of a flow diagram or a consort diagram as suggested in item 13. A flow chart should be easy to follow and allow the reader to easily determine how you selected your patient cohort. Once the cohort is established, clearly summarizing the characteristics of this cohort will allow the reader to determine differences between groups, or if you're comparing different treatment regimes, for example. Now, with respect to outcomes, it is recommended that you provide unadjusted and adjusted estimates of the effect. The purpose of the adjusted estimates is to determine the effect of the exposure, taking into account other factors which could also influence the size of the effect. A discussion of limitations is key and should be used to discuss your findings in the context of the limitations of your data, sources, and your methodology. And so really, this is a very brief overview of the Strobe and Record guidelines, and I would urge you to look at these in more detail at your convenience. So for now, we're going to look at this paper to illustrate some of the concepts that are contained within those guidelines. So this is a retrospective study that used the American College of Surgeons National Cancer Database to evaluate patterns in surgical care and their association with overall survival in women with stage 4 breast cancer. The study period is from 2003 to 2012, which is, generally considered to be a more modern period of time. So as mentioned previously, it is important to provide good justification for your study. And I think that the authors did do this, and I did not get the impression that this was just as a result of data mining. It is an important clinical question, as breast cancer is the most common cancer in women, with a proportion of women who are going to present with metastatic disease at the outset. The authors explain that existing observational studies have considerable limitations, including selection bias and treatment facility bias. And with respect to existing randomized clinical trials, they state that some of the previous limitations included insufficient systemic therapy regimes and treatment sequences that did not really match contemporary practices. And so with this in mind, the authors do try to minimize these biases in their study, which we will discuss a little bit later. So this cohort included women with intact primary tumors alive 12 months after diagnosis, who were then grouped by treatment sequence. And the sequences that we see do reflect what I see in my clinical practice. And this includes surgery before systemic therapy before surgery, and then systemic therapy alone. Now, this is the flow chart provided by the authors, and this nicely outlines how they narrowed down the final cohort after exclusions for non-invasive disease, missing survival data, missing data pertaining to sequence of treatment, and less than 12 months of follow-up time available. Now, in the final cohort, one can appreciate that the majority of patients had systemic therapy alone, which is what I would come to expect based on my clinical practice. Now, the authors clearly state their primary and secondary outcomes and planned analyses. The outcomes here are very relevant, and the proposed analyses seem quite reasonable and are commonly observed in studies that use population-level healthcare administrative data. Now, I think often the tendency is to just skim over table 1, as these tables tend to be quite large and they're often seen in small print. But I would urge you to take the time to look at this very carefully. So do the results make sense? Is this a cohort of patients whose characteristics would match that would match what you see in your routine practice? You can see here that all of the values are statistically significant given the large size of the cohort, but are these differences clinically meaningful or clinically relevant? For example, I see here that a greater proportion of younger women are receiving surgery after systemic treatment, which may reflect overall good health and therefore are more likely to be offered surgery. A greater proportion of women with T3 or T4 tumors receive systemic treatment alone or surgery following systemic treatment. So these two observations are in keeping with what I would expect. And really, if table 1 does not make sense to me or reflects a population that I don't personally encounter in my clinical practice, then I usually hesitate to move forward with the rest of the article. Now, next in this paper, we examine the treatment sequence and how this relates to treatment variables. There are a number of questions that one could ask, including, does the time to surgery make sense? Is the type of surgery offered in keeping with the expected operations for the disease? And is the utilization of endocrine therapy and radiation what one would expect clinically? We can see here that time to surgery after systemic therapy is about 4 to 7 months, which is what I would expect for time patients are on systemic treatment, and that the women who receive surgery after systemic therapy are more likely to undergo more extensive surgery, such as simple mastectomy, a modified radical mastectomy, and also receive radiation than those who received surgery prior to systemic therapy, who are more likely to be women who were thought to have localized disease, but shortly after surgery were found to have metastatic disease. It is also important to consider sites of metastatic disease, as this will affect prognosis. And most of these women have metastases to sites other than just bone, and this is equivalent among groups in the study. Now, the authors report their primary outcomes a couple of different ways here, one with the Kaplan-Meier curve, which I'm sure you have all previously seen in research papers, and the second by reporting 5-year, 10-year, and median overall survival. Now, we do appreciate here that women who received surgery after systemic treatment had better median overall survival at 53 months compared to women receiving systemic therapy alone at 38 months. Now, we examine this more closely in the adjusted analysis, where the authors attempt to adjust for confounding factors. Now, confounding is interference by a third variable that will distort the association between the exposure and the outcome being studied. Despite adjusting for relevant confounding factors such as age, comorbidity, TNN stage, ERPR status, etc., receiving surgery either before or after systemic therapy was associated with a reduced hazard of death compared to systemic therapy alone. Other factors that were associated with a reduced hazard of death were younger age, ERPR positive disease, partial mastectomy, and bone only as the metastatic site. So just a few thoughts on why the surgery group did better. Going back to table 1, they are younger, they're presumably fitter, and may be more likely to be offered surgery as part of an aggressive treatment regime. Now, as we all know, the fitness of a patient is not necessarily captured by the Charlson Comorbidity Index, which is a commonly reported index in these types of studies. Now, these patients had a greater proportion of patients with ER-negative disease and therefore more likely to have a better response to chemotherapy. They were also more likely to have private insurance, and this may be a surrogate for access to treatment that may affect their outcomes. This may lead to facility bias, whereby depending on where you get treated, that facility in general may be more or less aggressive in their overall approach to the disease. And finally, patients undergoing surgery first were likely thought to have localized disease, but then found to have metastatic disease shortly after surgery. And it may be that the burden of disease in these patients was limited, so potentially these patients ended up doing better than the others. Now, based on the discussion so far, I'm sure you can appreciate that studies that use routinely collected healthcare data for research contain a lot of data. It's also de-identified, and it does not affect decisions in real time. And so from an ethics standpoint, often no approval is required, which saves time and energy. It gives you a nice bird's eye view of patterns and trends in routine practice. And then signals in this data can be further explored, often with other methodologies. But the data is not granular, meaning you can't get down to the bottom of why certain regimes or treatments were offered. You cannot take into account the effective patient and family preferences. It is subject to biases and errors, and sometimes there are missing variables that will no doubt affect your outcomes and treatment decisions. So I think the authors report a thoughtfully done study here, and I've highlighted some of the points already. In this study, the authors were able to utilize this data to improve upon criticisms of other studies. For example, previous studies were plagued by small numbers, which is easily addressed by the large numbers contained within the National Cancer Database and other databases that are similar to this. The treatment sequence reflects contemporary regimes that many practicing oncologists would be familiar with. Another issue that is important is that of selection bias. So selection bias comes into play when the researcher decides who is being studied and the selection of participants is not random. Now, randomized clinical trials minimize selection bias through randomization sequencing, but that does not apply to large administrative databases where someone else has already decided who got which treatment. So in this study, the authors excluded women who were predicted to do badly and therefore limited the study to those who survived greater than 12 months after the diagnosis, which was in fact a major criticism of previous studies. Now, the issue of facility bias did come up in this study. So facility bias reflects the fact that certain facilities may be more aggressive in their overall approach to a disease, and surgery may be a part of that approach. It is also possible that this overall approach may result in improved survival, completely unrelated to the fact that a patient underwent an operation. The authors specifically mention and address facility bias in their studies through their statistical methodology. So I think that there are definitely limitations to consider here, including the fact that we really have no information on why these women underwent surgery. This is common in studies that use population level data, as there is no detailed information on why patients were offered a certain type of treatment over another. So in this study, was it for palliation of symptoms, local progression despite being on systemic treatment, or was it patient or provider preference? And importantly, there are variables in clinical practice that affect treatment decisions that may not be captured in routinely collected data. So for example, relevant outcomes not available in this particular data set included HER2 status and specific sites of metastatic disease, the number of sites affected. So basically the burden of systemic disease in these patients. So in summary, the utilization of routinely collected healthcare data for research is increasing, and it certainly offers many advantages. Convenience aside, it is important to be aware of strengths and limitations of these data, and we have highlighted really just a few of these today. In my opinion, it all begins with the right research question or objective, and you do have to spend some time justifying this and being aware of the existing literature in that area. The Strobe and Record guidelines are easy to access and are really, one useful tool to ensure that your study is conducted and reported in a way that tries to incorporate many, if not all of these elements. So I'd like to thank you for your attention and the opportunity to address the audience today. I've met very few of you in person, and I'm hopeful that as travel starts to open up in India again, that I'll be able to meet many more of you in person as well. So thank you very much.
Thank you, Dr. Shaila. I think the first two speakers have specifically talked about the role of RCTs, then the flaws in RCTs, that is Chris was addressing that issue. And again, in countries like India, where you have need more ground level data, you need to have the pattern of care studies according to the Dr. Shaila. But both has flaws as well as advantages. Dr. Manoj Pandey is a pioneer in the surgical research, because I think he might be the person who is having maximum number of publications among cancer surgeons in India. And I also see Dr. Somashekar, who has joined in. So, Dr. Manoj Pandey, can you, how do you look at this issue, the research, surgical research?
Thank you, Chandramohan. Am I audible?
Yes, yes, Manoj.
Yeah. Both the speakers, Dr. Shaila and Dr. Chris, has done a wonderful job. They have set the ground for a good discussion. The first thing that we have to understand is that there is no study which is perfect. So every study, whether it is an RCT, well-designed RCT, high-powered RCT, or a big sample size RCT, will have some or the other problem. And the problem is because humans do not follow mathematical models. So one or the other individual which is participating in the study will not be behaving as the rest of them are behaving. And this produces a problem. Second thing is that it is almost impossible to identify all confounders at the beginning. And use of statistics, if you know statistics, that statistics is hypothesis driven. And it is up to me what a priori I set. I can set any a priori I want. And I can design my study to prove my a priori. So the statistics is like that if you want to use it, you can actually use it to your advantage, which most of the people are currently doing, as Chris showed. It's not that all the randomized control trial which are being done are underpowered or using smaller benefits. Some of them are very well powered, some of them are giving very good advantage. And we are here today, and we have made so much of development in cancer care because of those RCTs which has been developed over a period of time. Especially the NSABP trials, like breast conservation, has been made possible because of clinical trials. AC regime has come because of clinical trials. So there is a lot of that advantage, survival advantage, which has been given to us by clinical trials. So what we need to understand is we have to separate the bad apples from the good apples. And this is for somebody to understand that for every surgeon has to know that how to interpret a paper when he reads it. A new evidence, a new clinical trial does not mean that a magic has happened. So you have to take down everything with a pinch of salt, start reading it, just like Dr. Shaila described, look for points, start criticizing it, and then you will see a lot of problems with that clinical trials. And it takes years before the clinical trials actually become practice. So rather than and the bigger when it comes to surgical clinical trials. Now, Dr. Shaila talked about selection bias. That when we have a retrospective study, we don't know why a particular surgical procedure is chosen. Now, when you come to surgical clinical trials, and especially if you are looking at retrospective data, there is a surgeon bias. See, if you remember my older days at Trivandrum, all lower OG junction tumors, esophagogastric junction tumors, I used to do a transhiatal surgery. Why my colleagues used to do a Ivor Lewis. So the surgical procedure is selected by the surgeon, or it is his preference, and it may have an effect on the outcome. So here, even what priorities surgeon has, a surgeon might be doing both breast conservations, a surgeon might be doing more mastectomies. For the same tumor, one person may do mastectomy, the other person may do breast conservation. So if you look at this data, surgeon-wise data, you are going to find that even the procedures between two surgeons are different. And all of them are ultimately going to affect the results. So there is a lot of biases that are introduced into the data, and it is for the reader to understand. Like Chris has been talking about pharma funding, and I'll say What about the publisher funding? Publisher publish because they have something called as a gold journals. They charge $3,000 and they publish anything. They are least concerned about what they are publishing because they are more concerned with the $3,000 per article that they are going to get. So we have a lot of publication bias. You have a negative study, possibility of it being published is very small. So you are not going to get published. Even Watson and Crick find it difficult to publish their helical data. It was published ultimately as a 500-word, one-page article. So you can understand that how this world moves. And you have to keep that in mind when you are interpreting the scientific data. So science is not as simple as we expect it to be. It is more complex. It is more complex, and it is for us to understand that what is happening. So pharmaceutical companies are one player, publishers are another player. Most of the journals receive advertisement funding or reprint, bulk reprint purchase from the pharmaceutical companies, so they benefit from each other. So this is a big thing which is happening, and this is what we need to understand. So rather than me speaking, I think we should take questions from the people who are attending, and let's try to answer those questions in true sense of a panel discussion.
Thank you, Dr. Manoj. Those are extremely helpful comments. Dr. Chandra Mohan, perhaps just before we open it for questions, if I may share my screen again, just to pick up on a few of the very important points that Dr. Manoj raised. And so I just want to share, can you see a screen now?
Yes, we can.
So this is, I didn't have time to get into this into my talk, but just to provide maybe a 2-minute summary of this paper we also published very recently in JAMA Oncology, because it highlights a number of the key points that Dr. Manoj Pandey commented on. So this was an overview of clinical trials from all over the world. And actually, our dear friend and colleague, Professor Pramesh, was one of the kind of originators. Pramesh, Richard Sullivan, and I were having chai one day in Mumbai, and anyhow, after a long discussion, decided we should do this study where we looked at clinical trials across the entire cancer landscape globally, and we found a number of important things. First of all, very few trials were published in surgery and radiotherapy, and I think that's a call to action for the surgical community. But one of the problems is it's much easier to get funding from a pharmaceutical company, and who's going to fund these clinical trials in surgery? But that's a concern because surgery and radiotherapy are the most curative intent modalities of cancer. So we have a problem when most of the trials are being done in palliative drug therapies. But here's some of the other things that we found that are really important. We found that there is a disconnect. Most of the cancers that are being studying are cancers that are traditionally in affluent healthcare systems and cancers of poverty. Head and neck cancer, cervical cancer, esophagus, liver cancer are much less likely to be studied. And then there's some important messages here from a global landscape. What we found is that clinical trials that come from low and middle income countries, there are many things we can learn. First of all, they are designed in a more sensible way. They tend to be slightly smaller, but they're powered to detect a meaningful effect size. They're not chasing trivial benefits. Despite that, clinical trials from LMICs are more likely to be positive, they're more likely to meet their endpoint, and they're more likely to identify large effect sizes. So there's actually a lot that we can learn in the high income setting from trials that are coming from more resource constrained settings. So this is this concept of bidirectional learning, where we have a lot to learn from our colleagues like you that work in healthcare systems where you don't have the luxury of wasting a lot of time and money on a trial of 3,000 patients to improve survival by 10 days. And so we found that. Now, here's the problem. And this is why I'm glad JAMA Oncology published this, because there's a huge publication bias against trials that come from LMICs. So I think this is one of the most important findings. So if we look here, the impact factor of where these trials are published, as Dr. Pandey commented, there's a lot going on in the background about where trials are published. So you can see here, lower impact journals, okay? So trials from LMICs are much more likely to be published in low impact journals compared to trials from HICs. Even when we control for whether the trial is positive or negative, you can see here a huge publication bias against trials from LMICs. So even a negative trial from an LMIC, it's published in a much lower, sorry, a positive trial from an LMIC is published in a much lower impact journal than a negative trial from a rich country. So there's a lot of structural problems with how trials are published. And when we wrote this paper, which I would encourage you to read if you haven't, we made a major call for, high income countries learning from some of the things that are done better in LMICs, and this idea that knowledge can flow in both directions. And I think actually India has the opportunity to be a leader in this regard through the National Cancer Grid and through establishment of research clusters to do pragmatic, practice-changing clinical trials that will lead to real benefits for our patients. So I just wanted to share a couple of those thoughts because Dr. Pandey commented on a few, I think, really, really important points. And certainly now I open Dr. Chandra for you to moderate the discussion or questions.
Dr. Shaila, would you like to say something?
No, nothing specific to add to that. I think the comments that have been made so far have been very enlightening and demonstrate that there are a lot of issues that we can encounter in the surgical literature. And it really behooves us as a community to take it upon ourselves to really learn about where the biases are and how to really interpret the findings of the literature that we are faced with on a daily basis. So no, I think it's been a great discussion so far. Thank you.
So Dr. Chris, you spoke about the biases of RCTs and we have to, so what's the way out? Shall we do more of a pattern of care research rather than RCTs?
Great question, actually. So Dr. Pandey was right in his opening comments. There's a lot of good that comes from randomized trials. So even though I made some critical comments about randomized trials, that remains the best way to identify new treatments for our patients. So we should not abandon the randomized trial. We just need to design them in a more thoughtful and pragmatic way. Now, our cousins south of the border in the United States, there's a huge movement right now to actually abandon the randomized trial and just begin to approve that they want to approve new drugs based on single arm trials. That would be a disaster. And I'm very, very worried that, I spend most of my time, as Dr. Aliyama and Dr. Yadav and Dr. Chandra on this call know, we do a lot of work in patterns of care. And there are many important things we can do with observational research that cannot be answered by a clinical trial. We can look at disparities in care, wait times, access to care, outcomes, many, many important things we can do with patterns of care observational research. But the clinical trial still remains the best way to test treatment A versus treatment B, and we should not abandon the clinical trial. We just need to be more thoughtful in how we design it.
Hi, Chris. I have a few suggestions. Can I?
Yes, please.
Yeah. So both of you have done excellent presentation. So a few comments. This really RCTs are showing a hype in the results. Primary, as Chris rightly pointed out, am I audible?
Yes, you're audible. You're not seen. Can you?
Yes.
It's heavily raining here. Heavily raining. So anyway, so RCTs, primary analysis, even though primary analysis is not showing statistically significant, but secondary analysis, people are commenting on the basis of the secondary analysis. That is what RCTs. But we have to be very careful in interpreting results on the basis of the subgroup analysis, because in the subgroup analysis, subgroup analysis do not have sufficient power. Sample size will be definitely less than the sample size targeted in the study. So what we can do a meta-analysis on the ball. If any secondary analysis, if we have obtained statistically significant results, we can do a meta-analysis related to that and conclude whether this is having sufficient power and results are consistent. That can be, we can check whether otherwise we can conclude that this is really hype, because sample size, less sample size do not have sufficient power. That is one thing. And then second thing regarding Shaila's presentation, that is, if you have a routinely collected data, as you mentioned, there are lot of misleading results will rise, even if you don't have sufficient information, not conducted the study properly. Routinely collected data will definitely, it will mislead it will interpret the result, interpretation will be really misleading then. Because routinely collected data, one thing which in LMIC's face is in a survival study, we are facing follow-up information for obtaining follow-up, sufficient follow-up. In any survival study, if we do not have sufficient follow-up, we should not analyze such data. For example, if we do not have follow-up, say follow-up is only say 70%, then the rest of the 30% might have obtained the event of interest. They might have, suppose our primary objective is overall survival, and if we have information only about 70% of the cases, the rest of the 30% might have died. So event might have occurred. So then if you analyze the data with the available information, in fact, the results will be highly overestimated. So we have to be, you got it what I'm saying, results overestimation. So interpretation will be highly overestimated results. So we have to be very careful in survival studies, particularly in low and middle income countries. We are facing a lot to obtain the follow-up. We do not have a social security number for tracing patients obtain. So in fact, we have to do active system, not passive system. So we don't get information. We have to really do the work actively. So active system, so lack a lot of such information. So that we have to be very careful. And second thing, if it is a routinely collected data, then it will be definitely a heterogeneous group of patients. If it is heterogeneity is there, we should not stick on univariate analysis. We should use only adjusted results, because that can confounding bias will be large in a heterogeneous population. So if it is routinely collected data, and if it is not collected properly, then the results will be really misleading. So two things we have to be very careful in a survival study. Follow-up information should be as maximum as possible, and we should not analyze the data with the available information. It is actually better than not analyzing the data. No information. It is worse than no information.
Thank you, Eliama ma'am. I think we will go to the next topic. There are a few people like to ask some questions, but I'll introduce the next issue also. Now, there is, we have spoken about the RCTs and the practice changing. Of course, that is the number one evidence creating machinery. But when you do some surgical RCTs, my issue is, there is, as Manoj Pandey has pointed out, there is some variation from surgeon to surgeon practice. So an RCT which is done by an fantastic surgeon, and that has shown superiority over the conventional procedures, whether that can be recreated by the other people across the globe with with people who may not be having his abilities. So that's another issue. So RCTs in surgical practice, is it acceptable, or is it a big flaw? I think Dr. Manoj and Dr. Shaila can answer, and of course Dr. Somashekhar and Dr. Ramakrishna can join afterwards.
Well, Chandramohan, you can definitely do RCTs in surgical practice, and there are number of RCTs in surgical practice. For example, you can see ductomucosal versus how do you do a pancreatic anastomosis, or there had been a lot in the regional lymphadenectomy. Say in ovary, if you see para-aortic lymphadenectomy versus no para-aortic lymphadenectomy, there had been a number of clinical trials. But the problem with clinical trials is, like as you pointed out, that whether the results can be reproducible or not. If you look at the Japanese results of D2 versus D3 gastrectomy, nobody has been able to reproduce them till date. So only Japanese are able to do. Either the biological behavior of gastric cancer in Japan is different than us. No country, no surgeon has been able to reproduce the same results. So there is a variation. There is a variation in technique. There is a variation in how thorough you are, how much time you spend doing a D2, how thoroughly you clear the lymph nodes, because the everything is now shifted to median number of nodes. Colorectal surgery 12 nodes, breast surgery 20 nodes. So you are not concerned. The moment you have 20 nodes, you say it's okay, fine. So I may get 20 nodes in just doing level 1 and 2. I may not do level 3. So somebody may just get it. So this way, there is a lot of variation in surgical technique. But my question is, surgery is a form of treatment which actually provide local control of the disease. And if you look at, except a certain circumstances where surgery is curable, all other places, the survival advantage actually comes from addition of either a radiotherapy or a medical oncology or a drug, adjuvant treatment. So surgery alone, and comparing the results of surgery alone on treatment is something which is very, very, very difficult. And that is what Chris has said, that most of the clinical trials which are being carried out in the palliative setting, because there the only treatment that you have is a chemotherapy or a immunotherapy or a new molecule. So there is no roll off. But when you are talking of a combination treatment, surgery alone for pancreas, what is it going to contribute? It is not going to increase your survival unless you add adjuvant chemotherapy. So the moment you add adjuvant chemotherapy, you have a confounder there. You don't know whether the survival is improved by the adjuvant chemotherapy or by your surgery. Like in breast cancer, if you do surgery alone, the survival is poor. So survival, actually, the overall survival is increased by addition of the adjuvant chemotherapy, and local control is achieved by addition of radiotherapy. So if you are not going to add radiotherapy or chemotherapy, your surgical results are always going to be poor. So that is why it is very difficult to compare surgical results. Yes, you can do surgical RCTs, but then you can do it only for 30-day mortality. So you can do surgical RCTs for complications of surgery. You can do it for a 30-day mortality and say that, okay, this procedure has this much of 5% operative mortality, this procedure has 1% operative mortality. Or you can say, if you do this procedure, you have recurrent laryngeal nerve palsy 1%, you have recurrent laryngeal palsy 5%. You do rectum in this way, you have sphincter preservation in this many percent, you don't have in this many percent. But actual disease control is not by surgery alone. So there is no situation in surgical oncology where surgery alone is the treatment. And that is the problem, except T1, T2, buccal mucosa or tongue, where you don't have to add adjuvant. But otherwise, you are very difficult going to find of T1 panis. So you are going to find very few situations where surgery actually is contributing to the survival.
I think we have a very fantastic panelist. You are actually giving the credit to other specialties. Like Chris was saying that medical oncology is not contributing much. And Manoj is saying surgery is not contributing much. And Shaila, what is your take on this issue?
So I think all of
you believe the controversial statement from Manoj that surgery is not contributing much.
Well, I think that certainly each modality has its role, and it really speaks to the fact that these cancers, really a multimodality approach is often indicated for maximizing outcomes for these patients. Just a thought about your comments earlier about variation related to the surgeon and the surgical technique, and so. You've probably seen this, Dr. Chandra. What I've observed is, in some of these surgical trials that are looking at management for gastric cancer, gastroesophageal cancer, Dr. Pandey spoke about extensive lymphadenectomy. We see a lot of trials related to laparoscopic approaches to the management of these types of cancers. When you look at their methodology and how they selected which surgeons were going to participate in the trial, these are high volume surgeons that are performing these types of operations. These surgeons are often required to submit a log of, their operative cases. They often have to submit videos of their surgical technique prior to being considered for being included in these types of trials. So it really speaks to the fact that sometimes we'll see an RCT, we'll read about it, and we'll think to ourselves, there's no way that I can mimic these results because I'm not a high volume surgeon. To the extent that surgeons in Korea and Japan are doing gastric cancer surgery. So it's a very valid consideration, and I think that we as surgeons really need to look at the results of these studies and really think to ourselves, are my surgical skills in line with the surgical skills of the surgeons that are a part of this trial? And in many situations, probably the answer is no.
Dr. Ramakrishnan, would you like to say something? Professor Ramakrishnan is from Adyar Cancer Center.
Yes, Chandramohan, thank you. So just continuing on that topic on the quality of the stringent criteria applied to surgical trials and gastric cancer, because that is what the discussion has been about. We can learn quite a lot from both the MRC and the Dutch trials on D2 lymphadenectomy. If you look at the MRC trial in gastric cancer, the average number of surgeries performed by each of the participating surgeons was probably just 2 or 3 in a year. Compared to that, surgeons in any of the Eastern countries perform nearly 50 surgeries a week. But then, as far as the UK is concerned, that is pragmatic conditions for the UK, because it's not a very common cancer in the UK, and most of the surgeons in UK actually do see only so many gastric cancers in their career. So that reflects what an average surgeon in the UK would be expected to deal with. So I think you need to look at the geography and the background where the trials are conducted to. So it is the surgical trials are a trade-off between pragmatism and the need for standardization and expertise. So I don't think you could say that you need to have strict criteria for enrolling surgeons, submitting videos, and minimum number of surgeries, etc. That may work in certain situations, but it may not be applicable to some other situations. So that is my take on surgical RCTs. But just deviating slightly, I would like to ask Chris, you had mentioned that rather than progression-free survival, you would consider an overall survival as a much reliable and useful endpoint. While I agree that that might be a valid thing for a metastatic disease, especially in a low middle income country like India, where it is the finances of getting treated for cancer is quite mind-boggling for most of the population. The first treatment that is offered to the patient is probably the best treatment that he can have, and that is probably the only treatment that he's going to receive. So do you think in a non-metastatic setting, disease-free survival would be a better endpoint than the overall survival? Because I could say with some sort of reliability that in India, once a patient recurs after the primary treatment, he is very, very unlikely to receive second line, third line, fourth line treatment. So the longer he survives after the first treatment is what is going to benefit him most. So do you think that same corollary applies to non-metastatic cancers as well?
Thanks, Ram. Great question. So listen, there are a handful of circumstances where progression-free survival and disease-free survival are very appropriate primary endpoints, okay? And that's usually when they've been shown to be valid surrogates in large analyses to correlate with overall survival. So for example, the disease-free survival example you provide, Dr. Ram, if in the Indian context, patients are not getting therapy after they relapse, then it should actually translate to an overall survival benefit. So certainly in colon cancer, we know disease-free survival is a very appropriate primary endpoint. In colorectal cancer, progression-free survival in the metastatic space is also a valid surrogate. So there are contexts where it is a valid surrogate. Someone asked a question in the chat about whether patients will still value progression-free survival. And my concern is that patients don't understand the term of progression-free survival because of the third word in that phrase, survival. And when we say this will improve progression-free survival, they don't hear the first or second word. They hear the third word. And we've actually done qualitative work in Canada where we've met with patients who are actually on chemotherapy, and we give them hypothetical scenarios where we ask them to imagine their disease has progressed, and we give them treatment A or treatment B, and we don't use the word progression-free survival. All we say is that if you take this treatment, the amount of time you live will be no different. Your quality of life will be no different. You will have some side effects, but they will be manageable. But your CAT scan will show slower growth. And uniformly, almost all the patients look at us and say, if I'm not going to live better and I'm not going to feel better, but I'm going to have to spend money and have side effects, I don't care what the CAT scan shows. And so when you use clear, plain, simple language, I think most patients, not everyone, but most patients will be able to understand it, and it will allow us to make care that I think is more congruent with their individual values and preferences. But it is an important context, to understand this. Those are all very important points. Just to comment on a few things in the chat, Dr. Pandey has raised important points. The quality of data in the real world can sometimes be very poor. And so I agree that real world data, it needs to be done in a rigorous way. And so Dr. Aliyama and colleagues at RCC Trivandrum have a very high quality population-based and hospital-based cancer registry. And so I think that we can aim to raise the quality of registries at centers across India to try to address some of these issues. But it's a very valid point that just because, as I joke with my colleagues, just because it's from the real world does not mean it's real good. And so we need to make sure the quality is high.
Somashekar, would you like to comment? I see him raising hands. Dr. Subramanian Rao.
Yeah, Chandramohan, excellent discussion. The issue is like everybody having presided over a lot of clinical trials as a principal investigator. I'm quite skeptical about pharma company sponsored funded RCTs. If you see nowadays, majority of RCTs are sponsored, financed, funded. ORSA's actually a investigator initiated. Because an investigator initiated without a sponsorship funding from pharma company usually is something hypothesis based which has been observed, and it's sort of it's really very truthfully the results come out. For example, when I do a sponsored pharma company multinational multi-institutional trial, the inclusion exclusions are so well suited for the drug. Many times it may not actually translate into real world scenario for us. And so that's something which I'm really skeptical. So when I really read a RCT, I just look at it. Is it an investigator initiated one or sort of a pharma company initiated? And second issue is many of the RCTs are performed under ideal testing trial settings, ideal trial settings. Many times they're not exactly replicable in real world scenario. And doing an RCT which actually may not make a difference in real world scenario is something which is no useful. I'll give an example. There are 7 phase 3 multi-institutional, multi-country RCTs intraperitoneal chemo for ovarian cancer. 7, all positive trials, overwhelming positive trials, significant p-value with right confidence interval and hazard ratio. Has it made a difference? Less than 2% of the people use worldwide. So, real world RCTs are extremely important. Equally important to back it up with is the real world scenario and the data which is going to make a real impact is something which we need to understand. And to add to what surgical trials are done, nobody funds surgical trials, nobody wants them, and then very difficult to standardize. A 2 to 3 months OS benefit in medical drug RCTs are sort of overhyped over years benefit of surgical RCTs. So these are a lot of inherent problem with RCTs which we have, which we need to really overcome this. There need to be a central body funding is received and sort of they do it neutrally rather than funding and pharma company doing that particular thing.
Thank you, Dr. Somsekhar. And there's an interesting chat which came from Dr. Mathumurali is regarding the guidelines. When you formulate, actually the countries where guidelines are made, they seldom follow it. But the countries like India, where we follow the NCCN and other guidelines, like we following the religious scripts. So the question is, when guidelines are formulated based on such an evidences which is not trustworthy, how are you going to create more evidences? Dr. Chris.
Yeah, so it's a great question from Dr. Madhu. We can have this conversation and we can all agree that some trials are useful and some trials are not useful, but then it becomes difficult in your OP when you pull up guidelines and the guidelines endorse these low value treatments. And so I think this is a process that's going to take some time. I think that just by having these conversations is really important, I think, within our community to acknowledge that some of the things we do have huge benefits and some of the things we do have very little benefit and are probably harmful. And I think by at least talking about this, it gets the idea out in the open, so it's not a hidden secret. We talk about it. And then I think eventually, it's going to be the next generation that I think will be more practical and common sense. And I think if we expose them to these ideas as they begin their career, by the time they begin to assume positions of prominence and start writing the guidelines, I hope that they will be more practical in their approach. But I know even just by raising the issue, the ESMO framework, their clinical benefit scale, has revolutionized health technology assessment in many countries now, where the government will no longer pay for medicines unless it meets ESMO's threshold for clinical benefit. And so that's going to change things, because now it means a pharma company, if they want this to be funded by the Ministry of Health in Austria, in Paris, in the Netherlands, they're going to think twice before designing a trial with a trivial benefit. Now, the elephant in the room is the US, right? As long as the US FDA does crazy things, it's going to be very difficult for the rest of us elsewhere in the world to have these pragmatic discussions. But the United States is not immune to these problems, and they're beginning to realize that they cannot continue to fund and provide all of these expensive therapies with trivial benefits. So I think the rest of the world can have this conversation, and one day the FDA might be willing to join us.
Dr. Manoj, any concluding remarks?
Murli has raised a very valid question, and I think the Chris has answered it very well. But one thing I want to say, there is also a tendency to get third world guidelines or Indian guidelines. And last time when ICMR was working on it, I actually went into an argument. I said, why do you want to compromise on quality of care? So people are ready to compromise on quality of care, like you get away with a chest X-ray rather than getting RCT. So such tribal things should not be made part of the practicing guideline. Another thing that has been in the country is like train general surgeons to do surgical oncology. There are a lot of people, even I came from general surgery background, with very little training, but then over last 25 years, I have been purely into oncology. And we now run a huge training program of ourselves. But what I'm seeing is that still there are a lot of general surgeons who keep on doing the surgical oncology work. And I say that the quality of the work which is done by a general surgeon who is not trained to do that procedure, who is not doing that procedure regularly, is going to be poorer than the person who does that procedure on a routine basis. Now, this is not happening. So when I was when I joined surgical oncology 25 years back, situation was different. There were hardly any surgical oncologists. There were 3 or 4. RCC Trivandrum was the 4th college which started. They had a team of 2 surgeons, and then I was the 3rd surgeon who joined there. And then slowly that department grew. So that was a different situation where you didn't have trained people. You have training the people, and you were working also. But today the situation is different. You have people who have been trained to do a procedure. Let those people do the procedure. Why let somebody who is less qualified do a procedure and then talk about surgical quality? So you can talk about surgical quality only when you produce people who are able to do a good surgical clearance. Even within the colleges, those who produce MCH people, the quality of training of all the institutes is not same. It is different. Some people, some students are better trained in thoracic surgery. Some people are better trained in head and neck surgery. Some people are better trained in breast surgery. We have not been able to put out a uniform curriculum for training. We have not been able to inculcate the uniform training. There are a lot of problems that are there. And then over that, we talk of quality of surgery. So when your training is poor, when you are not able to train people as surgical oncologists, they are taking 5 years, 7 years after doing their MCH to actually start operating of their own. So with their quality, what quality are you talking about? So senior people are okay, fine, but then what is the quality of the people who are just coming out? Look at your graduates who just pass out, how many procedures they can perform of their own. So this is what we need to actually work upon before we can talk about the quality of surgery. Or we can do the randomized controlled trials of surgery. We should have people who have the equal competence, equal outputs.
I think valid points. I think if you, it's good that we raise so many issues and the issues are unending. But even then, I think the coordinated, at least these are top thought-provoking issues, and we should try to address this and
Definitely.
move in a coordinated manner. I hope this meeting generated a lot of interest among the participants. And really thank Chris and Manoj for joining, and Shaila has already left. And it was an amazing meeting. Thank you very much. Thank you.
Thank you, everyone.
Thank you, Chandramohan. Thank you, everyone.
Thank you. Bye. Good night.
Bye.
Take care. Bye.